Not all women have what we would call a normal period, in which case they might present to a gynecologist for what we call abnormal uterine bleeding. Periods can be abnormal in various ways. They could be too close together or too far apart. You could have bleeding in between periods. Periods could last too many days out of the month, or periods could just be too heavy. The last category, which we refer to as heavy menstrual bleeding, is the one that we're concerned with for this research. Historically, treatments for heavy menstrual bleeding include hormonal therapy, commonly known as birth control, or hysterectomy, which is the surgical removal of the uterus. Since the 1980s, new exciting treatments have come into existence. In the way of hormonal therapy, women can now get an intrauterine system, which is a small device that sits in the uterus and gradually releases hormone and can stay in the uterus for up to 3 or 5 years. The new surgical treatment that was born for heavy menstrual bleeding is called endometrial ablation, which involves destroying the lining of the uterus, called the endometrium. Ablation of the endometrium can be achieved in numerous ways. You can literally boil it, freeze it, electrocute it, laser it, microwave it, and the list goes on. So why is endometrial ablation so appealing? Well, first of all, it doesn't involve any surgical incisions because we put the instrument through the cervix and right into the uterus. For this reason, there's much less surgical risk to the patient, and the recovery time is significantly reduced. As well, endometrial ablation is a lot quicker and cheaper to perform than hysterectomy, so it costs our healthcare system a lot less. Some endometrial ablations can even be done right in the gynecologist's office while the patient is awake and only take a few minutes. So if endometrial ablation is so great, then what is there for us to study? Well, in up to 30% of women who undergo endometrial ablation, heavy bleeding and or dissatisfaction with the outcome of their ablation occur within the first 10 years after the procedure, which ends up requiring additional treatment. This additional treatment could consist of medical treatment, a repeat endometrial ablation, or even hysterectomy. In this case, it may not be safer or more cost-effective to start with endometrial ablation as a treatment for heavy menstrual bleeding if there's the chance that the patient may end up undergoing more than one surgical procedure. In this case, we should just stick with hysterectomy as the primary surgical treatment. But what if there's a way to make endometrial ablation more effective? This is where our study comes in. We are currently studying an idea that came up in 1990 and had positive results published in 3 studies. The idea was to give women a shot of depomedroxyprogesterone acetate, or DMPA, immediately after their endometrial ablation. DMPA can be used as a birth control method alone in the form of a shot every 3 months, because the progesterone level can suppress your ovulatory cycle for 3 months at a time. In the studies, it reported that giving women a shot of DMPA immediately after their endometrial ablation increased the success rate of the ablation by increasing the rate of reduced to no menstrual bleeding 6 to 12 months after their ablation. And so, we are currently doing our study to confirm and corroborate these very exciting results.